Hello, everyone, and welcome to AHP Live from Advocates for Human Potential, where our experts look at issues affecting public health and human services organizations and give you real-world solutions for real-world problems. I'm your host, Kristen King, and I'm the Director of Digital Strategy and Online Events here at AHP. Today, I am joined by AHP's Director of Healthcare Solutions, Patrick Gauthier, and two special guests. We have Chris Chin and Maya Jolly joining us. They're both students in UCLA's Executive Master of Public Health Policy and Management program. I'm going to bring Patrick on the screen. And Patrick, since you know our guests well, I'm actually going to let you introduce them.
All right, terrific. Good to see you, Kristen. Let's start with Chris. This is a young man who's passionate about population health and value-based care, health information technology. And he's currently a second-year student in that executive master's program that you introduced there at UCLA, Kristen.
Thanks, Patrick. It's a pleasure to be here today.
All right. And then Maya has worked for a decade in healthcare administration, in the nonprofit sector and behavioral health organizations in both the United States and Canada, inspiring her to pursue that executive master's at UCLA to continue her goal of improving quality and access to behavioral health services. So help me in welcoming Maya.
Hi, everybody. Thanks for having me.
So glad you all are here. Patrick, nicely done. Thank you for handling the introductions today. So folks, Patrick, Chris, and Maya are co-authors of the new AHP report, Behavioral Health Access at California's Accountable Care Organizations, Implications for ACO Behavioral Health Across America. And today we're going to be talking about the basics of parity law and the nature of behavioral health services as essential health benefits. So after this conversation, you're going to have some new ideas and inspiration to help you operationalize some of the most important aspects of parity law within your own ACO system of care. And so to that end, Patrick, why don't you kick us off with a quick recap of this is a mouthful, the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act of 2008, or the MPHAEA for short. So give us a quick summary, Patrick. I think we're moving forward.
I do wish that they had come up with a better acronym. That would have helped. It's a word jumble. Maybe we can create one. Look at the Paul Wellstone and Pete Dominici. We owe a great deal to them and to Senator Kennedy before them, and to others who've been after parity. I think we can all sort of collapse the Mental Health Parity and Addiction Equity Act into the single word parity. This has been a goal, an objective, a vision for decades. And I know in the 3 decades that I've been working in this field, it's something that I've been an advocate for, chasing after, implementing in one way, shape, or another. But it was this particular version of parity, 2008, signed into law by then President George W. Bush. And it took some time for it to really begin to spread across the country, to be implemented fully. And that is oftentimes the result of a need for rules and regulations. Those regulations were really coming to fruition about the same time that the Affordable Care Act was signed into law by then President Obama, making mental health and substance use disorders an essential health benefit. That's important because what happened there is that the ACA, or Obamacare, amplified or magnified the impact of parity across all kinds of health plans. In short, what parity and equity means in law, in rule, and regulations is that coverage for mental health and substance use disorders has to be aligned with, on a par with, what are the predominant medical and surgical benefits offered by a variety of plans. And that sort of breaks down into 2 groupings. The first are quantitative, things you can measure, like your copay or the number of days something is available, the number of units, anywhere where you see a number, those have to be equal to. And then there are the non-quantitative, which might have to do, for example, we'll talk about it, level of care or medical necessity guidelines before your services can be approved by a managed care plan. So lots of complexity in here. I think we owe some of the slow implementation to the complexity. And now we're in an era of enforcement, and enforcement's going pretty darn well, and we'll talk some about that.
Great. Thanks, Patrick. That's a good overview. And for the folks watching, there is a lot of complexity here. So if you have questions as we go through, please feel free to type them in the comments on the live broadcast. If you're watching in the replay, you can also comment on the replay, and we'll come back and answer those questions. So you're going to see me looking to the side throughout because I'm checking those comments. And if any come in, I'll be the voice bringing them onto the screen. So with that, let's dive in. You all undertook a research project to understand how ACOs in the state of California are understanding parity and how they implemented it in their organizations. So Maya, why did you all pick California?
That's a great question, Kristen. In 2020, the California Governor Gavin Newsom signed Senate Bill 855 into law to bolster the Mental Health Parity and Addiction Equity Act in California specifically. That law took effect just in January 2021. So among other things, this law requires that health plans no longer use their own medical necessity guidelines to determine what conditions are covered and what services may be provided under what circumstances. Prior to this, health plans had a lot of kind of leverage in defining what was medically necessary, and that could cause problems for people who are trying to, get certain things covered where the health plan had decided, oh no, we're not going to cover that. So now the health insurers in California are required to use standard guidelines that are developed at the local level by nonprofit clinical associations. So we can have a little bit more confidence that these requirements are going to be standardized and evidence-based.
Okay, that makes sense. Thank you. So Chris, tell us why you all decided to zoom in and focus on ACOs specifically.
Sure. Yeah, I think regarding ACOs, one of the big reasons we focused on ACOs was because we really saw them as the model of the future. Over the last decade, they've really exploded onto the scene, starting with the Medicare population, but we also see commercial ACOs and other types of ACOs. And I think ACOs really have an opportunity to unite different perspectives and value equations from both the payer side, but also the provider side for the good of the community, like no other model can. So ACOs have so much potential here to coordinate that high quality care, and specifically they can integrate behavioral health. So I think as systems of care, ACOs should understand what is required of them by law. And really that said, it's imperative that regardless of the payer, ACOs should continue to grow and mature to include equitable mental health and substance use disorders coverage, access to treatment for these patients, and also fair payment to providers.
So when you looked at this, what did you actually find?
Yeah, it was actually quite surprising. More than half of the 7 California ACOs that we interviewed were not familiar with the specific requirements of the Federal Parity Act that Patrick had mentioned earlier, which was very surprising because, again, it's not a completely new act. It's been around for a decade. And so that was quite shocking to us, but also that 5 of them did not even view behavioral health as an essential health benefit. So, and that was one of the key aspects of the Affordable Care Act that was trying to push forth. So correlated to this, we found that these same ACOs, they offered very few behavioral health services in their network. Granted, they had various reasons for not doing so. There were challenges in that, but we also saw that they would refer out 95 to 100% of their behavioral health services out of network.
That's like a huge gap.
It is. And our respondents, like Chris said, they cited challenges, to offering behavioral health care services, including most cited the lack of interoperability between providers and also unsustainable payment models for behavioral health and a low supply of behavioral health providers. These are issues a lot of us are aware of that exist. But despite these challenges, their failure to understand and comply and failure to treat people's behavioral health needs is an abdication of their responsibility for whole person health. And it is easily correctable. There's things that we know we can do.
Okay. Well, we've talked a little bit about this in some of the other Facebook Live conversations that Patrick and I have had, and others about, how important it is to strategically factor all of these into your mix. So in this report that you all created, you offer 4 recommendations to improve ACO behavioral health services. So what I'd like to do is just go through them briefly. So Chris, why don't you tell us a little bit about recommendation 1?
Sure. The first recommendation would really just to focus on the education side. So educating ACOs, payers, and patients alike on the federal and also the recent state parity laws, and making compliance tools readily available so that we can track this. In our research, as well as our literature review, we found that there's just a significant lack of understanding on how behavioral health services should be covered compared to standard medical benefits. And we found that even on the patient side, patients didn't know that they could basically expect the same across both of those different types of services. So we think by adding more education as well as reporting tools, we can really help ACOs meet this critical patient need.
Yeah, this, if I can interject just a second, this really goes to the desire on our part to look in California. There are states like California, New York, whose attorney general have been very aggressive in enforcing parity laws. California's had some very significant, headline grabbing enforcement efforts. I'm not a proponent of using enforcement and class action lawsuits, to get people to comply with the law. I think that education is a much easier, softer, gentler way to get there. But I think we need to, as policymakers, as payers, as providers, advocacy groups, we need to work together to make sure people are properly educated. Otherwise, we have to fall back on enforcement, which I think is an unfortunate outcome, but it's a necessary one.
Thanks, Patrick. Maya, why don't you tell us about the second recommendation?
Sure. Our second recommendation is to encourage the Medicare Shared Savings Program, Medicaid, and commercial ACOs to add quality pay for performance metrics for treatment of substance use disorders as well as mental health disorders. And by providing this financial reimbursement, this type of benchmarking is key for incentivizing those ACOs to integrate behavioral health care services. It's like the carrot and the stick kind of story. Like we want to give them a lot of incentive to actually provide behavioral health care services and integrate, because ACOs are really focused on cost savings, and that's kind of their reason for being. If they achieve shared savings, then they continue and they improve. And so really adding these kind of behavioral health focused pay for performance metrics is a key way that will change things.
Yeah, I can really see how the combination of the education and the incentives is going to create more lasting behavior change than just like dropping the hammer, right? Like, because this really is a process that we're all engaging in together to get those better outcomes. So I appreciate that connection. Chris, why don't you take us into recommendation 3?
Yeah, our third recommendation is really focusing on demonstrating to ACOs that the integration of behavioral health services into their medical and primary care settings can really help further their organizational, financial, and quality goals, especially as it relates to sharing health and behavioral health information. One of the key challenges that we had mentioned earlier was the lack of interoperability between PCPs and behavioral health providers. And a lot of times, those sensitive notes and that type of information doesn't always get back to where it needs to go. Mm-hmm. And really an easier way to improve care coordination would be to utilize the same network, the same EHR, and then to really close the loop on these referrals and make sure that all of the patient's care is really well coordinated and integrated. And that way you can achieve the best quality outcomes as well. If
I can, I'll jump in too, Chris. I think that's an excellent explanation. ACOs are, the tip of our spear in this country with regard to population health management. And population health management is predicated on the notion that I can look at my population, my assigned population, and see risk in that population. By seeing the risk via my data, I can then stratify my population into high risk, moderate risk, low risk, and begin to fashion solutions and interventions that are appropriate to each group of population. If I don't see the behavioral health data, if I don't see the social determinant of health data, I'm missing a really big chunk of information about that patient, about their family, about their community, and about the population I'm serving. So what Chris is saying about interoperability of data, a sharing of health information and other information as it relates to social services or human services, absolutely critical if we're going to do to the cost curve what we're hoping to do.
Thank you. And Maya, finally, tell us about recommendation 4.
Our final recommendation is to provide technical assistance to ACOs, behavioral health providers, and networks to further the cause of sustainably utilizing non-physician providers like social workers, recovery coaches, and behavioral health care managers in the treatment of the whole person. So the ACOs we interviewed that were succeeding in integrating behavioral health told us they relied on these providers to fill current gaps, and other ACOs can easily do the same. The ones that weren't making efforts towards behavioral health, they didn't have these providers on hand because they hadn't made behavioral health a priority. But the ones that did, they were definitely utilizing alternative providers like social workers to coordinate care and also provide care.
Thank you. So I see how these 4 recommendations are really working together. We're educating and providing the information that they need about what is necessary. We're incentivizing them to put it into practice. We're connecting with the data that they need to be sharing to see the whole picture and really support people. And then we're also recommending this hands-on support to help them use the full range of services that are available so they can more effectively achieve these goals and implement these recommendations. So I really like how you structured this so it all fits together. And I want to let everyone know there's more detail on the data, the research methods, and the recommendations in the full report, which we'll talk about in a minute. But Patrick, let's zoom out for a second. What do ACOs actually need to do in order to be able to implement these recommendations?
Okay, well, the first thing they need to do is commit to learning what's in law and what's in regulation. A compliance officer needs to sit down and review, and there are all kinds of tools that have been prepared by others. As Chris said, this law is not new. The regulations aren't new. They've been around for a long time. So somebody needs to, be dedicated to learning. The other is to commit their system of care. ACOs are, by design, a highly integrated system of care to some level, some degree of redesign to address behavioral health with as much rigor and a sense of innovation as they would to any other specialty. If they were looking at redesigning for the sake of diabetes, or as cardiologists in their network might want to see some redesign, bring that same gravitas to it, and then make behavioral health a central feature of value-based reimbursement schemas or mechanisms to ensure that everyone's working toward the same ends.
So what happens if they don't?
Oh, if they don't, look, after more than a decade of educating policymakers, payers, providers, the marketplace has really begun to focus on enforcement. Okay, and that's what I was referring to earlier. If they don't want to address this, then unfortunately the enforcement mechanisms that exist, whether they're through the IRS, Department of Treasury, Department of Labor, CMS, or at the state level with attorneys general. Enforcement is the only recourse. And they can expect it at some point. That enforcement will be directed toward them.
Okay. So to that end, what invitation do you want to offer to the ACOs who are watching this discussion today?
Well, I'd say that, we've learned something important from COVID-19. Among many things, what we've learned is that we can redesign, innovate, and deploy new technology, new approaches very quickly. We all did it, behavioral health, medicine, with telehealth. Telehealth to me is a wonderful example because it's the kind of innovation that a lot of people hemmed and hawed about, and they said they wanted to learn more about it, and more research needed to be done. They had all kinds of reasons to hem and haw. But when push came to shove with COVID-19, my goodness, the fields of medicine and behavioral health were able to pivot, implement, and deploy telehealth like none other. It was miraculous around the country. And I think if they apply the same gusto to parity and equity, we'll have terrific results. So let's learn from painful examples. Let's learn from the past, including let's learn from what it means to have discriminated against behavioral health for so long. Let's learn from the law, learn from the regulations, design, innovate, and integrate. And then let's demand that that new system of care produce as much value as possible. I want to hold behavioral health providers as accountable as anyone. Let's produce that value. We have to.
I love that. Thanks, Patrick. Well, and so folks, to help you learn from these examples, as Patrick and Chris and Maya are suggesting, and to really take on these recommendations, we're going to make their full report available to you at no cost. So I'm going to drop the link. I'm not going to drink the link. I'm going to drop the link into the comments on the live broadcast. And I'm also going to add it to the video description for our replay viewers. It's about 25 pages. It's a PDF. So you can share it with your colleagues. And they're just going to walk you through the background for this conversation in a little bit more detail, the research methods, and really look more closely at those findings so you can see what it really means that more than half of them had a gap to fill in terms of clarity and understanding and implementation. So I'm going to put that link in the comments. Here we go. And please do feel free. Oh, hang on a second. Let me do that again. Please do feel free to share that as you find useful. You can pass that link along to anyone. You can also share this recording. It will be available on our Facebook page, and we'll also put it on our YouTube channel. So with that, okay, I'm going to let Chris and Maya have the last word here. What is the most important thing for our audience to walk away with today, other than a copy of this report? Chris, I'll have you go first.
Thank you. I think really in the last decade since the ACA, since ACOs and population health really started to gain this traction, I think we really have to learn that we can't expect the best value or the best outcomes in a system that doesn't fully address behavioral health and social health for that matter for its members. I think really that's why this work is so important, because at the end of the day, the patient comes first. And we want to provide the patient with the best value-based care, and that really entails, not only medical services, but also behavioral services as well.
Thanks, Chris.
Really well said, Chris. And for me, I would say that we need to raise our expectations. Population health and whole person health really must address the health of our most complex organ and what makes us human, which is our brain. We can't just leave that out of the equation. Providers know that behavioral health is really important in whole person care. They just feel like there are too many barriers to achieving behavioral health. So we need to help them break down those barriers.
Thank you. What a perfect note to end on. Patrick Gauthier, Chris Chin, Maya Jolly, I thank you so much for joining us today. I want to remind everyone to be sure to download that full report, Behavioral Health Access at California's Accountable Care Organizations, Implications for ACO Behavioral Health Across America, from that link in the comments and also in the video description on the replay. Folks, I'm Kristen King. On behalf of my colleagues at AHP and my digital strategy and online events team, thank you for joining us, and we'll see you next time for AHP Live.
Thanks very much.
Thank you.